Hi, how are you?
So it's a great pleasure to receive you here. Although I prefer to be in personal, but
Yes,
now we
yes,
have just this online way of um, talk now. So
yes.
thank you so much for
You're
accepting our invitation to participate in this webinar. It's a great pleasure to receive you. And please go ahead, whatever you want. Michelle is just to a brief introduction. Michelle possui graduação em medicina pela Columbia University College of Physicians and Surgeons. Ela trabalha no serviço de transplante do Hospital Beth Israel Deaconess Medical Center em Boston e é professora adjunta da Harvard Medical School. Michelle, please.
Thank you so much, Carolina. How do I share my screen? I'm so sorry.
In the right corner, if you see in the bottom.
Okay.
Probably there is a show now.
Yikes.
In the right.
Okay,
on the right and the bottom. On the bottom.
There we go. Can you see it now?
Yes.
Okay, great. Let me
just to the present button.
Right. Okay, great.
Here you go. Yeah.
So, Carolina invited me to talk about our specific protocol at Beth Israel Deaconess, and I sort of tried to understand all the other previous presentation, and it seems like the previous speakers gave a really nice overview of and details about sort of vaccinations and the recommendations. So I'm really focusing on what we do and our protocol at Beth Israel Deaconess Medical Center. And the immunization recommendations are for solid abdominal organ transplant. So at Beth Israel Deaconess, we do kidney, pancreas, and liver transplants. We don't do lung and heart, so I'm not covering that. And I'm also not covering the immunization protocols for your BMT and other hematologic malignancies. So nothing to disclose. So this is a picture of Beth Israel at Deaconess when Carolina arrived in Boston. She arrived in January, I believe, right in the middle of a snowstorm. So in case she was missing the snow,
yes. Exactly like
yes, yes. And so, I know this was sort of reviewed earlier, but in terms of timing of vaccination, we really make every effort to vaccinate prior to a transplant to produce a more robust vaccine-specific immune response. And so at our initial evaluation, before we even decide whether to list someone, we start checking serologies and we start the vaccination process. The optimal timing of post-transplant is not known, but our protocol is to try to vaccinate at least 3 months after the transplant to improve vaccine-specific immune response. By the time we get to 3 months, the immunosuppression has come down and the patients are off of steroids. We don't do live vaccines post-transplant. And really this table, I think you've seen a lot of tables tonight. But this table is similar to what you've seen, but for all patients, we make sure that they are vaccinated against diphtheria, tetanus, pertussis. That's every 10 years it is inactivated, so safe. We check for hepatitis A and B immunity, and if they do not have immunity, we vaccinate them, and we do check titers after to make sure that they've responded. The HPV vaccine as well, we do give, and that's a one-time. And for flu, we give yearly, but we do not give the flu mist, which is a live attenuated virus. And we'll also go over our protocol for household contacts as well. So people who live with our patients. And as for the pneumococcal vaccine, I'm going to go in detail about our protocol on the next slide because it's a little bit more complicated in terms of our protocol. The 2 vaccines that we do give only pre-transplant and not post-transplant are the MMRs, and varicella. And I'll go over that a little bit more. So for our pneumococcal vaccine, there are two formulations. There's the 13-valent protein conjugate and the 23-valent polysaccharide. So depending on what the patient has received, that will determine what we give them. So if they've never been vaccinated with a pneumococcal vaccine, we give the PCV 13 first dose, then we wait at least 8 weeks, and then we give the PPSV 23. If they've gotten a dose of one or more dose of PPSV 23, then we just give the one single dose of PCV 13 dose at least 1 year after the last vaccine. If they're older than 65, then we do the PPSV 23 at least 5 years from the last dose. And then these, as I mentioned, these are the vaccines we only give pre-transplant because they're live attenuated. So for the measles, mumps, and rubella, we only give it pre-transplant. We also avoid if we're anticipating transplant within 2 months. And this is always very difficult because we're sometimes if someone is deceased donor, we're not sure when they'll be transplanted. But if their MELD score is high, then we generally avoid within the last, we avoid vaccinating these patients. The two varicella vaccine, one is if they are VZV IgG negative, meaning that they have not had chickenpox or have been exposed to varicella. We give, we transplant just adults, so really 2 doses 4 to 8 weeks apart. And we do check the antibody 4 weeks after final immunization. If the titer is equivocal or negative, then we repeat with a booster. In terms of the Shingrix, and that is for if they're VZV IgG positive, meaning that they have been exposed in the past, and this is to prevent shingles, we do the 2-dose vaccination series with the Shingrix. So in terms of special population, I'm just only going to briefly touch on it for our protocol. It really is just meeting with our infectious disease specialists and finding out where they're going and discussing the travel-specific vaccination. And I know Dr. Cotton will cover this in the next lecture, but oral typhoid and yellow fever vaccinations are contraindicated after transplant because they are live. So in terms of our other special population, HIV and AIDS, the MMR and varicella vaccines are contraindicated in patients. In patients with CD4 count less than 200. If they're over 200, it's a case-by-case sort of discussion with the patient. In addition to other standard vaccinations for these patients, we give the quadrivalent meningococcal conjugate vaccine. So basically the meningococcal vaccine, there are different brands, there are many formulations. I will go over it in a subsequent slide on this. They're given 2 doses 2 months apart, and we boost every 5 years. So the other special population are patients who get a splenectomy, have functional asplenia, or anticipated use of eculizumab, because these patients have additional risk for infections due to encapsulated organisms. So in addition to the vaccinations I mentioned above that we give for all our patients, these patients in particular need the HIV vaccine. That's just given once. And also the 2 types of meningococcal vaccine. So the quadrivalent conjugate vaccine that I mentioned for HIV and AIDS patients, and also the meningococcal serotype B vaccine. And so I put down sort of the groups where the 2 different meningococcal vaccines are indicated. So for the first one, HIV, if they're in college or university, high-risk travels, and also if, as mentioned above, if they're having a splenectomy or having the anticipated use of eculizumab. For meningococcal B vaccine, military travel to high-risk areas and sort of what the splenectomy. For the quadrivalent conjugate vaccine, we boost every 5 years. For the meningococcal vaccine, serotype B, we boost at 1 year after the initial vaccine, and then every 2 to 3 years after that. Now that's off-label use, but that was sort of issued by the American, the official guidelines. So a little bit about our protocol for the vaccination for the household contacts. We do recommend that they get vaccinated for all the things that are recommended, but the special precautions that we do talk about with our patients and their household contacts are to avoid live inhaled influenza vaccine. So the flu, here it's called the flu mist. If a live vaccine is inadvertently received, we ask that household contact stay away from the transplant recipient for 7 days. In terms of rotavirus vaccine for infants, the transmission risk is theoretical. The viral antigen is detected in 50 to 90% of the infant stools. There are no reported cases of symptomatic infection in contacts, but to be cautious, we do ask that the patient or the transplant recipient avoid handling of diapers for 4 weeks after the infant received rotavirus vaccine. And we also ask that all household members should wash hands after changing infant diaper. And as I'm sure Carolina is very aware, we should still wash hands after changing infant diaper anyways, regardless of the rotavirus vaccine. And finally, you know, we don't know and no one knows. And I think the next thing that we do want to watch out for and that we're waiting for is a COVID-19 vaccination and the recommendation, depending on what type comes out. So this was a very brief presentation, but that's our protocol.
Michelle, thank you so much. This is the idea to know about the protocol that you follow at BI. In fact, the protocol are very, very similar to between US and Brazil. But during the routine of your service, who are the professionals who check about the immunization? Is it the doctor? Is it the nurse assistant, the nurse physician?
Gotcha.
Who is responsible for this kind of monitorization?
Yeah, so you know, we have our standard panel of blood tests that every person coming for evaluation gets checked. So we order them. But, you know, I will have to say our nurse coordinator are the really like wonderful nurses who really make sure this is done. So they go through the checklist, they make sure that, you know, if someone needs vaccination, they flag it. And then, and if they do need consultation with our transplant infectious disease specialist, that they're seen to discuss, you know, what else they need. And we have patients that immigrate here from everywhere. And so they're born elsewhere. They're also seen by our infectious disease specialists.
Right. Yeah. We were talking about this topic some minutes ago with Dr. Raquel, one of the presenters today. And just because of this great important point that doctors usually don't spend so much attention about immunization, although everybody knows that is so important. And we are following this idea of keep together everybody, nurse and doctors, care about immunization in a more practical and routinely way.
Yeah, and I think that, you know, as we start relying a lot on electronic medical record system, we also start creating more tools. So we have, you know, in our medical record system, a sheet. So it's a flow sheet, easily tells you and flags, you know, these are vaccinations the patients need. But the tools are only as good as the people who use it, right? So the tools are there, but you do need someone to look to make sure that they're done, especially for the ones that are time sensitive, where you don't want to give things too close to the transplant.
Yeah, correct. Michelle, thank you once again